Hi, this is Andrea Kane, and I'm here with HIT 340 Comparative Records. It is now week 10, and we are looking at chapter 11 in our book on rehabilitation. If you are looking at your syllabus, we are on course objective 8.8, and that correlates to unit objectives 9.8.1 through 9.8.10. So if you're looking at your syllabus, those are the objectives that we're going to be working on this week while we work on chapter 11. So let's talk rehab. Our book says our learning objectives this week are to identify and describe the various levels of rehab care, the major accrediting agencies for rehab, members of an interdisciplinary rehab team, and the key features of IRF PPS. So that's the IRF Prospective Payment System. We are also going to talk about the classification systems that are used to grade severity of injury, disability, and relate them to outcome measures. We will be defining basic rehab terms and distinguishing between the concepts of impairment versus disability versus handicap, I should say. We will also be looking at sample forms that are used to track a person's progress in rehab and explain current trends in rehab. So what is rehab? It is the development of a person to the fullest limit of personal potential, including their physical, psychological, social, vocational, avocational, and educational aspects. So that is what this is all about. There are rehab units in hospitals, just like we talked about last week with long-term care units in hospitals. They are typically transferred elsewhere when maximum short-term improvement has been reached. Then there are long-term acute care hospitals. They bridge the gap between an acute care hospital and rehab programs. There are also acute care rehab hospitals that provide inpatient rehab services. And those are considered freestanding rehab hospitals. And again, they have the acute rehab part. They also have post-acute rehab centers. To give you an example, I know of a young woman who had a very traumatic accident. Two cars were racing down a street in a town. In a 35-mile-an-hour zone, they were going 70. And one lost control of his car, and it went off the road and across a patch of land and hit two people who were walking on a nearby sidewalk from the back. It threw both of them 80 feet. And then when they landed, obviously they had some pretty traumatic injuries. They were airlifted to an acute care teaching hospital. They were treated and taken to surgery. They were in the ICU, and then they were transferred after a week or so in ICU to an inpatient acute rehab center. And they were there for varying amounts of times based on their injuries. And now both are out of the acute rehab part of the hospital, of that freestanding rehab hospital, and they're receiving post-acute rehab on an outpatient setting. So that just gives you an idea of an example of where that would happen and what's the difference between acute and post-acute. Skilled nursing programs, yes. We talked about long-term care and skilled nursing facilities as well as skilled nursing units last week. It can be a wing of a nursing home or hospital, and it's dedicated to rehab care. It may be patients with multiple problems, or it may be older patients that are progressing more slowly, but in those rehab wings of these skilled nursing facilities, they're getting rehab services as they would in perhaps an acute rehab center, but less intensive. There's outpatient rehab. You often see a physical therapy clinic in a small town where patients can go in and receive outpatient rehab. They can also go into an outpatient rehab department of a hospital and receive care. These are patients who don't require hospitalization or overnight stays. And then you have home health rehabilitation, where you have patients who are in their homes, they're receiving home health care, And it's noted that they also need some physical therapy or some occupational therapy, and the home health agency will send out a physical therapist or an occupational therapist to work with a patient in their home a couple of times a week. And that's when it's, when the patient has difficulty leaving their home to go to an outpatient rehab facility, this is a great option for them through home health. And next week, week 11, we will be talking home health and hospice. So we'll touch on rehab through home health then. Types of caregivers that you're going to see in the rehab setting include a physiatrist. Notice that, a little bit different, not a psychiatrist, but a physiatrist. And if you're not sure what that is exactly, please look it up on the internet. Occupational therapists, physical therapists, speech language pathologists, psychologists, rehab social worker, rehab nurses, and kinesiotherapists. And then, of course, there's others. But again, everything is really focused around where's the patient at currently and how can we get them to their fullest functioning level in all those areas that we talked about at the beginning back on this slide. So that's what all that team of people is working toward. So types of patients you might see: orthopedic patients, someone who's had a hip or knee replacement or who's had a traumatic spine injury, those types of things. Neurologic, stroke patients are oftentimes the types of patients that need rehab. Some medical patients need rehab services. Maybe they're just not strong enough and they need some strengthening, some muscle strengthening to be able to help themselves and get better. You will see pediatric rehab for children. Perhaps there's a child suffering from muscular dystrophy. Sorry, I got to spit it out there. And they need rehab care. Management of acute or chronic pain. A lot of acute or chronic pain may be muscle-based or it may be nerve-based, and it may be helped or lessened by physical therapy or some type of rehab. Sensory impairment sometimes needs rehab. Spinal cord injury, I mentioned those, and traumatic brain injury. Those are all the different types of patients that you may see in a rehab setting. Terminology describing functional limits. Okay, so here's where we talk about what is the difference between impairment, disability, and handicap, because these mean 3 different things. If there's one slide this week that you need to memorize, it is this one right here. Make sure that you are very clear on what it means for impairment versus disability versus handicap. Please, please, please. Hint, hint, hint. All right, durable medical equipment is often used with rehab. You may have orthotics, and those are something in your shoes that support the foot and can actually help. People often find that they may have hip or back pain and come to find out it's because of their feet. And when they get orthotics and they wear those consistently with their shoes, it changes their posture back to what it should be and it takes away that pain. So a lot of times durable medical equipment is a necessity as patients are going through rehab. Ambulation aids like canes, walkers, prosthetic devices. You think about people who have had amputations, whether that is a military type situation or whether that is an accident, traumatic injury type situation, or whether it's a person with diabetes or vascular issues and they've had to have an amputation. Wheelchairs are part of durable medical equipment, and so are assistive devices. And some of those can be environmental control units. And it's good if you get a chance this week, take a few minutes and go Google high technology assistive devices and see which ones are new to you. See which ones you haven't heard of, because they've come out with a lot over the last 10 years. Regulatory issues. There are different groups that accredit rehab facilities. The 2 main ones are Joint Commission and CARF. And I'm most familiar with CARF. That's the one that I've seen typically for rehab settings, but Joint Commission does it as well. And then CMS, of course, has their own regulations on rehab facilities and rehab services. And your book covers this. So take a look at that for the definition of the 60% rule, for how they look at medical supervision and other services, and then their pre-admission screening. So I'm going to refer you to your book for that. All right. Also, organizations that are accredited by the Joint Commission can choose to have disease-specific care certifications, and then they give you some examples. Documentation. Okay, there is quite a bit of documentation required by rehab facilities or rehab services. First of all, when you're first bringing a patient in, you have to have a history that includes a functional and social history, as well as a physical exam. You need to have that preferably from a physiatrist as well, in addition, with the history and physical diagnosis. Because remember, just like you would in any setting, you need a physician to provide a history and physical, which includes the exam, as well as diagnoses. Federal regulations require that type and frequency of services be included. Pre and post admission documentation is required. Plan of care be done within 4 days, and that rehab uses an interdisciplinary approach. Therapists have to document, nurses have to document. There needs to be a discharge summary. When the patient's finally released from rehab care, there has to be a discharge summary. And then if there are any CARF requirements, those need to be kept in mind and documented. And you'll have an assignment this week on CARF. So hopefully that will help understand or build out some more of that. And then functions of the interdisciplinary team. Why do you need an interdisciplinary team? What are they all doing? How are they working together for the good of the patient, for their improvement? And then a rehab assessment. Medicare uses a prospective payment system to pay for rehab care, for inpatient rehab care. They use case mix groups that depend on the impairment categories, the RICs, rehab impairment categories. Then they look at levels of functional and cognitive impairments, the patient's age, and any comorbidities. Because the more comorbidities that a patient has, that affects the weights. So obviously, if you have a patient that has multiple comorbidities, they're going to need more care, and they may need a longer rehab stay than someone who is young, healthy, who doesn't have comorbidities. The IRF-PAI is what captures necessary information to assign the CMG, and the CMG is the case mix group. Okay. Data is encoded and transmitted within 17 days of discharge. There is quite a bit of information flow, as you can imagine, because again, you've got an interdisciplinary team caring for the patient, and then you've got the federal regulations of what you have to report for reimbursement and just in general for what's happening with Medicare patients particularly. Coding, they will use ICD-10-CM for diagnosis. But also notice that they're using IRF-PAI for an etiologic diagnosis. So make sure that you're aware of that weird twist. And then CPT is obviously used for all the therapies and the provider activities and charging and all of that. And then there's something called ICE, International Classification of Functioning Disability and Health. And I would encourage you to take a look at that. Look that up, Google it, read about it in your book. Trying to keep this lecture a little bit shorter than some of the other ones have been. So that's why I'm going to refer you back or refer you to Google. Electronic information systems, there's IRVEN or IRVEN. And that's one that if you don't have software from a vendor, you have to use IRVEN to report the information. Just like with long-term care, we talked about how you use Raven. or you use software from a vendor. And here it's Irvin, or software from a vendor to report that required information. And then, of course, there are national databases on rehab. So classification of rating systems. The American Spinal Injury Association is involved with this, and one area that they specifically focus on is traumatic brain injury. You may have seen in your classes with Shelley Grant about the Glasgow Coma Scale and the Rancho Los Amigos levels of cognitive function scale. So make sure that you are familiar with what the Glasgow Coma Scale is and the Rancho Los Amigos levels of cognitive function scale. Make sure you understand what those are and that they are used with traumatic brain injuries. Self-care assessment scales and FIM scores. These are looking at the patient's ability to care for themselves as well as their independence. I mean, they're kind of one and the same. Can you care for yourself? Can you do the activities of daily living? And how mobile are you, and that type of thing, as well as how independent are you? How much can you do for yourself without having other people do it for you? This FIM is incorporated into the IRF PAI. There are 13 motor areas and 5 cognitive areas. And they have to do the scoring on this repeatedly because they want to be able to assess the patient's progress. And there's something called WeFIM for pediatric patients. So make sure you're aware of that. And you can read about the CATS index or the Barthel index in your book or Google. Absolutely, there's quality improvement, and there's constant program evaluation. First of all, is there a multidisciplinary activity going on? Is the patient the person increasing in their ADL, activities of daily living skills? Is there an increase in their physical functioning? Is there an increase in their cognitive and emotional functioning as well? Are they adapting to their situation? An example, my grandmother had a major stroke when she was in her early 70s. And we found out later through some scanning that they did that it turned out she had a malignant brain tumor, and that's what caused her stroke. However, when she had her stroke, it really changed. She was no longer able to do a lot of her ADLs. Her physical functioning was such that she was wheelchair bound. Her cognitive and emotions were very much affected, and she had a very, very difficult time having gone from being perfectly active first thing in the morning to 2 hours later having had a significant stroke and lost a lot of her independence. And she struggled with that adaptation. And so it was very helpful that this was something that they watched, that they tried to work on, that they involved the family with. And then, of course, we talked about the FIM scores and then evaluation of the program. Is the program working? And if so, how well is it working? So utilization management is looking at appropriateness of the rehab services. Is the patient in the right level of service? If they're an inpatient, can it be done in outpatient? If they're inpatient, should it be skilled nursing? All of those types of things are being assessed by utilization management. And then, of course, they look at pre-admission screening. I mentioned that young couple that was hit from the back by a car that was racing and lost control. When they were in the ICU, that's when they had the physiatrist come over, as well as members of the inpatient rehab facility. They came over, they did a pre-admission screening. They identified what services the patients would need, when could they be transferred, and when they were transferred, what all would need to be done. And did it make sense for them to be in that setting, that level of setting? So pre-admission screening is done. Discharge determination, before they were both discharged, and they were discharged at different times, they had to assess that and say, okay, you've reached the point at which we really can provide you with services and maximum rehab capability. So now we need to talk about a different level and maybe move from inpatient to outpatient, that type of thing. And so determining, okay, once you've hit these levels of functioning, you're able to be discharged and either continue on an outpatient basis or you're done altogether. So they have to be looking at that. There are plenty of risk management and legal issues as well in rehab facilities. There are responsibilities of the rehab team when it comes to legal and documentation and reporting. They need to have a life care plan. There's sometimes third-party litigation, and then there's something called Medicare Set-Aside Trust, and I'm going to, again, refer you back to your book and to Google for that, because we're already at 20 minutes. Eek. All right, role of health information manager. Again, it's the traditional services, it's the management of the record, it's coding, it's auditing, it's making sure the documentation is timely, accurate, complete, helping with accreditation activities, tracking patient outcomes. I talked about coding, and then revenue cycle, timely submission of information, whether that's billing information or patient information that has to be submitted. Trends. Skilled nursing rehab programs continue to increase. You think about, we talked about that last week with long-term care and how there's an increased need for long-term care. Well, rehab in the long-term care setting is also increasing as well. Acute inpatient rehab beds are decreasing, but they're still there and available for traumatic injury type patients and those types of things. There has been a proposal to bundle payments for post-acute care providers with acute hospital payment. Looking at that, if you have a patient, let's say, that's coming in for a knee replacement and they're going to need rehab after surgery, they're looking at, can they bundle the payment and say, okay, hospital XYZ, we are going to give you this lump sum of money, and you not only have to pay yourself, but you've got to pay the surgeon, the anesthesiologist, as well as wherever they end up going for rehab. They all get their cut. So that's being kicked around, and I'm sure in some places is actually being piloted. Then there's impact, outpatient rehab, independent living, and then of course technology. Technology keeps changing and improving when it comes to rehab. If you get the time, you might want to look at trends in rehab technology and just see what you see. It's interesting to find out where that's going. So in summary, rehab is a continuum. It involves all age groups. It's provided in numerous types of settings, and they also have challenges in developing their health info systems. Rehab hospitals tended to be paper-based. They've moved now more electronically, into electronic records, I should say, but some may still be hybrid at times. So web activities, again, I told you about bundle payments. Go take a look at that if you are interested. You don't need to write a report, but it would be really good for you to know that information. All right, that's it. We made it. All right, hope you're doing well. Have a great week 10, and we will be back in week 11 looking at chapters 12 and 13 on home health care and hospice. Take care.